You're watching Cable 8, Greensboro Community Television.
Hi, thanks for joining us once again for Greensboro Glimpses. I'm very happy to have as my guest on this program the President and CEO of Hospice and Palliative Care of Greensboro, Patricia Soenksen. Pat, thank you so much for being with us.
Thank you, Jay. I'm happy to be here.
Great. This is an organization that's been around since, I guess, 1980?
Mm-hmm.
And
yes.
Started receiving your first patients in 82, so long time in Greensboro. And,
absolutely.
Doing a wonderful work in the community and throughout the country, as Hospice, of course, is a national organization. I think it might be Pat was on the program with us, we figured, I think, about 5 years ago, and
yes.
A lot's happened since then, and we want to talk about that, but it might be well to begin by just explaining to our viewers a little bit about what Hospice and Palliative Care is, what you do.
Sure. Thank you, Jay. I think the best place to start might be to talk a little bit about what hospice is, first of all, because I think sometimes there's some confusions about what hospice is. And the model of hospice originated in Great Britain and came to the United States in the late 1970s. And that's actually grassroots hospices, just like ours, sprung up, in the early 1980s, late 1970s. And hospice is really for individuals who have a life expectancy of 6 months or less if the disease runs its normal course. Now, that doesn't mean they can only receive hospice for 6 months. If they continue to decline, our physicians would recertify them. But I think it's really important to kind of put it in the context of 6 months or less, and the focus is really on care and comfort and not on aggressive cure. And so if someone is very actively seeking treatment, or they maybe want to go on a clinical trial, that person is probably not a good hospice candidate. And then I think the other pieces of the hospice model which make it really wonderful, it's really based on the concept of the patient and the family as the unit of care. In many healthcare settings, your relationship is with the physician. They're focused on you, just you as the patient. Mm-hmm. And in hospice, it's really the patient and the family, however that's defined. Families mean lots of different things. A family could just be grandmother, or it could be children. So the patient and the family is very important in that model also. And it's also, I think, one of the most beautiful pieces of hospice is it's built around this interdisciplinary team. So that care is provided by physicians. Our physicians work with, the patient's own physician, family physician, if they have one. We have nurse case managers, we have social workers, we have chaplains, we have bereavement counselors for after the patient dies. They help the family. We have hospice aides who provide a lot of personal care. We have volunteers. So it's this wonderful group of a team that comes together, and it really is focusing on the patient's physical suffering, pain and suffering, but just as importantly, their emotional and spiritual needs. Because sometimes patients, we have their pain and symptoms managed really very well, but they have great suffering, and it's spiritual and emotionally suffering. So I think that's kind of the hospice model of things. And so as it translates to our organization, we have about, like for instance, right now, about 350 patients under care. Mm-hmm. And those patients they're either, the majority of them are in their home. So of those 350, let's say about 300 of them are in their home. And by home, I mean a home like you and I would live in, or their home could be an assisted living or a skilled nursing facility. So wherever they call home, that would be about, for us right now, about 300 patients. And then we have another 40 children who are in our children's Kids Path program. And then we have an inpatient facility, Beacon Place, which we're very proud of. And we have 14 beds, so it's a hospice inpatient facility. And we have any given day, 11, 12, 13 patients there. So it's a mix of the majority of them in their home or in long-term care setting, and then children also in their home, but they're in our Kids Path program, and then Beacon Place.
Okay, now what's the difference between hospice and palliative care?
I'm so glad you asked that, because a lot of people are really confused about that. I talked a little bit about hospice being focused on life expectancy of 6 months or less if the disease runs its normal course. It's that team model, care and comfort, not cure. Palliative care is different in that it really is for anyone with advanced illness or serious illness, but it's at any stage, and it's not tied to that life expectancy. So we're also, with palliative care, focusing on care and comfort and management of symptoms, trying to reduce pain and suffering. We do a lot with patients in palliative care to help clarify their goals for care. Now, we do that in hospice too, but let's say somebody is in the hospital and they've had a very serious exacerbation of their illness, and they are in a lot of pain and suffering, and their symptoms need management. Then, of course, there's a wonderful palliative medicine team at Cone Health. We have a connection to that team, but that team can meet with the patient and the family and clarify the person's goals for care, and then also put them on a path in terms of managing their symptoms and pain and suffering. So I guess one other difference, Jay, since you asked about the differences, and it's an important one, hospice is covered by the Medicare system. So Medicare has a very good hospice benefit. It covers all of the visits by all those team members I mentioned to you, the nurse, the physician, the social worker, etc. It covers all the medications needed by the patient related to the terminal illness. It covers all the equipment. It just covers everything. So it's a wonderful benefit. Medicaid is structured the same way, but the majority of our patients are covered by Medicare. A small portion are covered by Medicaid, and those are many of our children in Kids Path. And then some private insurance will cover hospice also. In palliative care, it's a little bit different. There isn't a specific palliative care benefit under Medicare. So if someone is receiving palliative care treatment in a hospital or in a home or in a clinic, their physician is just going to bill under normal Part B Medicare, things like that. So.
Well, that leads me to ask you something I was going to bring up a little bit later, but since you're talking about that, what has been the impact, if any, of the Affordable Health Care Act on hospice and palliative care?
That's another very good question, and I like to think about it in terms of, I tell our employees, to kind of take the politics out of it. People have different views about it, but as a nonprofit organization, it's not our place to weigh in on whether we like it or not. But these are kind of the realities of it. There are some positives of the Affordable Care Act and some negatives impacting health care, and then there's some uncertainty. On the positive side, some things, you've heard a lot about accountable care organizations. There's a very impressive one connected to Cone Health. A large number of physicians are in this Accountable Care Organization, ACO, and that, I think, holds great promise for the future of healthcare. And actually, we're doing a little bit of partnering with them, so that's a positive side. It's also been shown the Affordable Care Act, or Obamacare, whatever people call it, has been shown to really reduce the number of uninsured in many states, North Carolina being one of them. So that's obviously good. And then there's some recent data that is showing that the rate of healthcare spending is actually slowing. So I think it's been running about 3.7%, where, as you probably know, in years past it was 6%, 7%, 8%. So health economists don't know for sure if that slowdown in healthcare spending is totally due to the Affordable Care Act, but there's probably some factor of that. Now, on the flip side, some negative impacts of it, hospitals are certainly seeing, and we are too in hospice, we're seeing reductions in reimbursement. So Medicare reimbursement, those things are being cut, and that's a negative to all of us who are in those areas. Hospitals also face penalties for readmissions if they have readmissions over certain levels. I think Cone Health is actually doing well in that area, but a lot of hospitals around the country are really struggling with that. But hospitals, Cone Health and hospitals all around the country are finding their inpatient volumes are declining, and some of that is probably related to several factors, maybe coming out of the recession or in the recession, but also the Affordable Care Act and declines in reimbursement. Another thing that's a negative, I think, under the Affordable Care Act, and it's not maybe the act itself, it's just kind of the impact of things. There's been increases in health insurance. So when people lose their job, many times they lose their insurance, and then you also find a lot of companies are changing their benefits. Their costs for health insurance are going up, but we found that ourselves. And so they're changing, modifying their plans a little bit. And then certainly the Affordable Care Act carries with it a lot of extra regulation. And some of it is good, it's monitoring fraud and abuse and things like that, but additional regulation adds a lot of cost in healthcare. So those are kind of some negative impacts. And then the uncertainty, I guess I would say, is we've all read a lot about the fact that through the Supreme Court decision, states were allowed to decide whether or not they would expand Medicaid. And North Carolina at this time has decided not to expand Medicaid. And again, kind of taking the politics out of it, it does have impact, great impact, I think, for healthcare systems, hospitals particularly. We have a small portion of Medicaid, only about 3%, but it's very important for our children's program. So we watch that development carefully and what is happening with that. But I could imagine if I were working in a hospital, you're really watching that carefully. So it's had some positive impact. It's had some impact that has been negative, and then it has some impact that we have to watch carefully.
Yeah. Well, the insurance aspect may have a direct bearing on something else I wanted to ask you. You mentioned a few minutes ago that you now have about 350 patients under your care. That's a tremendous increase from the last time that you.
Absolutely.
What accounts for that? Why do you have so many more now? Is it because of the availability of insurance?
It's interesting, Jay. I think really in the last, when I was here 5 years ago, I don't even remember, but I'm sure our census was probably maybe 2/3 of what it is now. But in the last 10 years, we've gone from 170 patients to 350. So we've literally doubled. And your question of why is a good one, because recently there was a Gallup poll, and it said to people, what do you want at the end of life? And interestingly, they wanted three things. People wanted to be in their own home, they wanted to be surrounded by family and friends, and they wanted to have relief from pain and suffering. Well, my gosh, that's the hospice model right there. Other things, that I think are important that we see every day is that with 350 patients, not a day goes by, Jay, that we don't get letters and cards from families, praising our care team for the work they're doing. So we know just anecdotally that people love and value our service, and then we get that positive feedback. But we also do a survey for all of our families. 6 weeks after the patient dies, we have a survey that goes out, and our results are actually even a little bit better than some of the national data, where if you ask, would you recommend this hospice to others, I think the national data for hospice is something like 97%, and I think we're at 98%. So it's anecdotally, we know it's good. We know if you do a survey that people, that's what they want. We find that's the case. And also, in this era of diminishing economic resources, it's a very cost-effective model. Medicare actually Duke University did a study a couple years ago, and they found that hospice Medicare saved the Medicare system about $2,300 per beneficiary. So I think I want Medicare to be around when I need it in a few years, and we all know that that's not going to be around. Maybe, I think the latest projection was it would be solvent until year 2030. But we all have an investment in making sure it's there, and to find something that's so beloved by patients and families, and it's the right thing to do, and it's cost effective. Gee, that seems like a wonderful model.
It does. That's very, very positive. You often hear the expression, a hospice has been called in. Who makes that call? Does it have to be the physician, or can a family request that?
That's another very good question, Jay. Really, anyone in the community, if they, let's say, my husband or a family member has been under treatment for a long time, and they've actually done well with their treatment, but now it really seems like they're really wearying of the very aggressive treatment maybe, and they're saying, I don't want to do this anymore. I can just pick up the phone and call our number